My name is Julie Davey and I'm a consumer, and I'm excited to be chairing this morning's panel and starting off a bit nervously, so be gentle. I wish to begin by acknowledging the traditional and ongoing custodians of the country on which we meet today, the Wurundjeri people of the Kulin Nation, and pay my respects to elders past, present and emerging. I also wish to extend that respect to other Aboriginal or Torres Strait Islander Australians present today. You might have seen on your way into Melbourne yesterday, if you were flying in, a large bird sculpture that near here, and that's the ancient spirit guide of the Wurundjeri people called Bunjil. And so if you see that bird, you can see that he's sort of still looking out across Melbourne in spirit. As I said, I'm excited to be chairing this panel today, and I'm taking part in this conference as a consumer representative and as a consumer member of the Victorian Integrated Care Model Steering Committee, a very exciting development. My experience with the health system is multi-layered. Before experiencing a major stroke in 2015, I had worked for 20 years in executive leadership roles in the Victorian health system, which makes me wonder why I'm nervous today. Anyway, I managed primary and community health services, rehabilitation services, statewide acquired brain injury services and health promotion services. During this same period, I was also primary carer for my daughter who has a chronic health condition, and for my mother who had brain tumours and neurological disease, and I cared for her 24/7 for the last 6 months of her life until she passed away at our home. After my stroke, I then experienced emergency, hyperacute, acute and subacute hospital care, and I was then a consumer of outpatient and community rehabilitation, so I figure I've done the rounds. What I want to achieve through representing consumers at conferences like this is to be more than a story. A lot of people talk about it's great to hear consumer stories, but I want to actively promote the particular expertise and knowledge of consumers such as these sitting with me on the panel today that they can bring to the table. And I guess I want to challenge the notion that consumers only have their lived experience, as if those PJs have defined them forever. I want PJs. Is that only something in Australia? Pyjamas? I want to encourage every health service to improve the integration of care through mature and respectful co-design with consumers as a matter of course, not just as something that they might choose to do as an add-on. I would like to now welcome our first speaker, Danny Vadasz. Please come up, Danny. My apologies for sitting down today. I hope everyone is right with that. So Danny was appointed Chief Executive Officer of the Health Issues Centre in November 2014. Prior to this, he spent 5 years at the Australian Conservation Foundation, Australia's foremost environmental agency, as Deputy CEO and Chief Operating Officer. With experience in business leadership, management, communications and marketing, Danny has a long history in the health, corporate and not-for-profit sectors. He has worked extensively in health, environmental and social issues promotion and in developing social enterprise initiatives. He brings energy, knowledge and commitment to achieving better consumer health outcomes with and for consumers. Thank you, Danny.
Thank you and good morning everybody. Good to see you here. Just out of interest, can I ask how many consumers we have? And I know we're all consumers, but how many people are here in their role principally as a consumer representative? Okay, a smattering. We'll come back to that issue a bit later. But look, in the first instance, this presentation I'm about to give I normally do in an hour, so you're going to get the white knuckle version. And I think I see my role today as challenging some of the preconceptions we have about how we're going with consumer participation, what we could be doing better, what we're doing well already. And some of it involves, I guess, some uncomfortable truths, and for those people who find some of what I say not to resonate or to be uncomfortable, give it a chance to settle in, think about it. As that famous American philosopher Vox Mulder once said, the truth is out there, even if it is inconvenient. So what I'm not trying to do is diminish the important work that many of us have already done in this space, but to say, okay, where do we go from here? What's next? What haven't we achieved in consumer participation? What are the limits and what could we be doing differently? So I've titled the presentation Consumer-Driven Outcomes, Putting Consumers Behind the Wheel. Because I guess our view is that the next phase of consumer participation is not so much about centeredness, it's about moving the consumer from being a passenger to being the driver. First of all, and this isn't going to work, yep, a little bit about my sponsoring organisation, the Health Issues Centre, for those of you who haven't come across us. We're a Victorian-based social research, policy development and consumer advocacy organisation. We've been around for 30 years. We work with all the principal stakeholders in the health system, so of course health professionals, health services, commissioning agencies, researchers, policymakers and academics, and of course consumers. And for the purpose of today, I want to make a differentiation in terms of what we mean by consumers. And it's not the one about we're all consumers, even if we're also health professionals. I want to differentiate between those consumers who we would call engaged consumers. The consumers, for instance, who are my colleagues on the panel today. Those consumers who, for whatever reason, have decided that they want to be part of a process of systems reform and change. And then there's the rest of the world, which we would call everyday consumers. And I think that's a differentiation we don't make often enough when we're talking about consumers as if it's just a single homogenous collective of people. So we work with all sorts of consumers, and the four arenas we focus on are capacity building, training. We provide a lot of training courses for consumers and health professionals, because believe it or not, the ability for health professionals to work with consumers isn't innate. It's a learned skill for both parties, and particularly if you're going to collaborate together, then you need to share common languages, common understanding. So that's a space that we've worked in for many, many years. We also recognise, as many of you do, the importance of culture in change and the importance of driving cultural change. We also, as a small organisation, understand that in order to have any impact at all, we have to work in collaboration. So we're forever looking for partners on the ground. So if any of you have interesting projects that you want some assistance with, it's our role to make sure that the work that we do actually works in reality. I sometimes characterise, if I'm asked for an elevator speech, that Health Issues Centre specialises in working in the valley of death between good policy intention and what actually happens on the ground. And that's the reality, you know, we don't need more frameworks, we don't need more elaborate diagrams that describe the problem, we need solutions, and we need solutions that work in a practical space. So, that's who we are, and as I said, we work particularly with consumers. Oh yes, and the fourth quadrant, conversations. A lot of what we do is talk to people. It's really innovative and sometimes digital, sometimes not, but more of that a bit later. Okay, so what do we mean by consumer participation? And I guess there are two dominant paradigms in terms of when we talk about the role of consumers. One is around consumer engagement. And the normative model in terms of consumer engagement is to rely on people that we call consumer representatives. And they're generally selected primarily because of lived experience, but increasingly we expect them to operate in some very sophisticated environments. So we have consumers in governance advisory roles, in quality and safety committees, in systems monitoring, communications roles, and of course in what we sometimes euphemistically call co-design roles. So of course it's nice to say, and you know this was just alluded to in the preliminary introduction, it's nice to say that we need consumers because of the lived experience, but the reality is to be a consumer representative, you need a whole range of skills. You know, you need to be health literate, you need to understand the system from a population health basis and epidemiological basis, you need to understand the difference between primary, acute, state, federal, you need to be articulate, You need to have time on your hands because consumer meetings are usually convened in highly, inconvenient times. You need to be economically independent because you very rarely get paid for your work. So in fact, if you look at the key selection criteria for a successful consumer rep, it's a very demanding role. And it takes a heck of a lot more than simply a lived experience to be effective in that role. So earlier this year, we were actually commissioned by Safer Care Victoria to have a look at the role of consumers, both as consumer reps and also as part of what we have in Victoria that is actually mandatory in a number of health services, and that is consumer advisory committees. And for some reason I have to click this several times before anything happens. And one of the questions we wanted to answer was, well, who are these people? Who are these consumer reps? And what makes them inclined to become consumer reps? So I think we all have our suspicions that there are certain sectors of the community that are overrepresented when it comes to consumer representation. And certainly statistically, the research we conducted makes that quite profoundly clear. So 67% of consumer reps are women, 71% of them are tertiary qualified. 60% formerly worked either in the health, welfare or education sector. 70% are retirees and 82% are over the age of 55. Now that's not in any way to diminish the contribution of that cohort, but that is not a cross-section of our community by any means. So we found that, and we also found that a lot of health services recognised. In fact, there were 2 or 3 common barriers that health services talked about in terms of their difficulty in making consumer advisory committees and consumer consultation effective. And one of them was this understanding that it was a fairly narrow cohort of people who were attracted to the role. And so the approach to that has been, well, let's recruit for diversity. So then we asked the question, well, can you in fact recruit for diversity? And I borrowed this diagram with acknowledgement from Bolton Clark Institute. So it was interesting that when we asked people about how they recruit for diversity, the first thing that became obvious was there's a whole range of definitions of what we mean by diversity. For some people it was, well, we need gender balance. For some people it was, we need good geographical representation because we cover a large catchment. For some it was, well, we need broad professional representation, although I have to say, of all the professions that were represented, we found no blue-collar workers. For some people it was, we need a broad range of conditions, or we need communities such as LGBTI, ATSI, ethnic communities represented. So there wasn't even a consensus of what we meant by diversity. And of course, diversity is an incredibly broad thing. This is just a snapshot representation that gives an indication of the enormous variations in human experience. You can never fit that many people on the table. And of course, the people who ultimately go missing from the table are the very people who we acknowledge, because of social determinants, are denied access and equity to the health system. And the same barriers, the same social determinants that are barriers to equity and access, are barriers to participation. So we think we need consumer reps. We do need sophisticated consumers who understand the system and can talk in systems language. But the rest of the community, those people who aren't highly health literate, who aren't engaged, also have a right to have their voices heard, also have a right to participate. So what do we do about that? We asked ourselves, what would best practice look like? If we took all those things into account and said, we want consumer participation to be a universal sport, not an elite sport, what would it look like? And the definition we came up with was that a true participatory model should embrace diversity, the vulnerable and the seldom heard, so that they too may influence outcomes. And we say influence because unless you hold plebiscites, you can't have everybody participate in the decision making. And believe it or not, most consumers don't necessarily want to be part of a decision-making process. You know, I want the trains to run on time. That doesn't mean I want to draw up the timetable. Consumers want to know that the system takes their circumstances, their hopes and concerns into account and comes up with solutions that meet their needs. They're happy for those decisions to be delegated to a representative, but the important thing is how do we create conduits between those people who are or seek to have a representative role and the rest of the community who they seek to represent. So we've worked hard on this problem in the last 2 or 3 years, and we've come up with a model, a bit different from the IAP2 model. The problem with the IAP2 model is on the left-hand side everybody gets information, and on the right-hand side a small number of people make decisions, and there doesn't seem to be any way of moving from the left-hand side to the right-hand side of the column. So we've come up with what we call a model of consumer-driven outcomes, and it consists of 3 important components. The first is what we call social listening, which is a process whereby we try to make sure that people can participate, not by raising their health literacy, but by lowering the barriers to participation. So we use a number of mechanisms, including social media, and largely social media. And when I say to people that our favoured research tool is Facebook, they raise their eyebrows. But let me just point out that there are over 18 million Facebook accounts in Australia. Between Facebook and the smartphone, we have the 2 most ubiquitous communications tools ever invented. And the other beauty of Facebook is its wicked algorithms. You know how you open up your Facebook account, those of you who admit to having one, and there's an ad and you go, how did they know I wanted to buy an alpaca this week? We can actually use those wicked algorithms to advantage by defining who we want to reach and targeting those people specifically. So 2 years ago, when we did some seminal work at the time on identifying the extent of suffering and adverse outcomes resulting from the use of transvaginal mesh implants, we identified the cohort that we wanted to reach by searching for people who had identified pelvic prolapse and urinary stress incontinence as personal issues. And Facebook allows you to do that. So social listening is not just about using social media, but it's an important component. It's also about talking to people in their comfort zone. So we don't drag people into focus groups in our offices. We go out to public transport hubs or to the local market. If you're worried about diversity, go to the local fruit and vegetable market like Victoria Market. The whole world passes you by in 15 minutes. And we'll interview them. Vox Pops. We also use a range of other methodologies that I haven't got time to talk about today. From that, we then go through a process of insight generation. Where possible, we include consumers in that. So we have deliberative forums where we take all the data and say, help us make sense of this through sentiment analysis. And then we apply that through a design brief, not to co-design. We stopped using that term because unfortunately what we hear about as co-design too often is euphemistic, and co-design too often brings consumers into the process right at the end, like when it's time to choose the fonts and the colour scheme. Human-centred design is about getting consumers to participate in the process of defining the problem before you start finding the solution. So out of that comes truly person-centred outcomes. We've used social listening in a number of circumstances. I'll only give you one example today because there isn't time, but we've actually developed 4 programs around it. So we apply it for Searchlight program, which is actually having a look at what are the emerging issues over the horizon that haven't hit the headlines yet, which is how we detected the extent of transvaginal mesh, the failure of other medical devices, and a whole lot of other issues that hadn't yet been quantified or recognised. We use it for stress testing. So sometimes good policy has unintended consequences. So we use it to see and measure what are the unintended consequences of the policy innovations that we're intending. We use it to look at social context. So we're all infatuated at the moment with big data. Now, big data is great for predicting trends, propensity rates, all sorts of things. But small data, which is the collected, aggregated, lived experience of 100 consumers, gives you the insight as to what's driving the data. And finally, we use it as part of the process of human-centred design. You can find out all about this if you're interested from our website or catch me later. Today we've only got time for a real skim run through this, but I'm going to give you one example of what the difference is. So people will say to me, but we do consult with the rest of the community. We apply surveys. And it's not to say they're of no value, they're of incredible value, but they have their limitations. And I'll just give one example of a social listening exercise that we were engaged for by a Central Victorian Health Service Hospital, Maryborough District Health, where they wanted to develop a community approach to defining what was important in terms of establishing a women's health and wellbeing centre. So we sent out a survey and asked questions, which of the following are most important to you? And they're the results we got. But then we looked at the conversation that we were having simultaneously through T for 10s, social media conversations. And what we found out was we had the right answers but the wrong questions. So where we asked people the importance of location, the conversation showed that what they really cared about was access. People would say things like, mental health problem doesn't wait till 9 o'clock in the morning. So it wasn't the geographic location, it was access to the service was important. When we asked them about integrated health, yes, so they said that was terribly important. And when we asked them what their understanding of that was, they said, oh yeah, we want complementary medicines. We want yoga classes. And most interestingly, you'll see that the highest rating variable was the need for confidentiality and privacy. And we said, so you've got concerns about data security, have you? And they said, no, we just want a back entrance. Because we're a small country town and we don't want to be in the waiting room and have our neighbours come in and say, what are you doing here? So as we say often, the real value in having conversations with everyday consumers is not that they know all the answers, but they'll challenge your hypothesis. They certainly know what the right questions are. And as soon as you have a different perspective of what the problem is, it changes the intervention. So that brings us to patient-centeredness. We'll leave that. And what is patient-centered care, particularly in the context of integrated care? So there are a lot of definitions of patient-centered care. In fact, even the terminology changes. Patient-centered care, patient-family-centered care, person-centered care. But centeredness always seems to be the key of what we're talking about. So there are two expressions of what patient-centered care is that I think is particularly relevant and interesting in the context of integrated care. The first, this comes from a UK organisation, National Voices. And one particular consumer said, well, for me, patient-centred care is when I can plan my care with people who work together to understand me, and my carers allow me control and bring together services to achieve this important outcome. And from a systems approach, the definition I like of patient-centeredness is the patient's perspective should be the organising principle of service delivery. Should be the organising principle. But is it? I mean, if you look at the various models of integrated care, as this one from King's Fund, you'll see that down there, service user, carer, the consumer is an input. Certainly not the central part of the organising framework. So there are many definitions of patient-centred care. You'd be familiar with some of them. I guess one of the most common is the PICA model with the 8 principles of patient-centredness. And you'd be familiar with many of the attributes of patient-centred care. We've had a look at a variety of the models, and basically, we believe there are 2 pillars of patient-centredness. One is about the quality of care, and that deals with issues such as dignity, respect, compassion, comfort, and emotional support. But then there are a whole lot of aspects of patient-centredness which are about the management of care. And we do a lot better on the quality of care than we do on the management of care. That's around opportunities such as setting goals of care, informed choice, integration of care, minimally disruptive care. So we've decided that we need a new model, a new terminology. So instead of patient-centred care, we now talk about patient-driven care. And we've come up with a nifty acronym because nothing's true in the system unless you have an acronym. And it's called the driver model of care. So in the driver model of care, D is for decision sharing. R is for respect, I for integration, V for validation, E for empathy, and R for remedy. And this isn't our model. This is what we've deducted from hundreds of conversations with consumers where we look at what the common elements are to what's important to them. So in terms of decision sharing, it's about goal setting, informed choice, financial consent. Can't begin to tell you how important out-of-pocket expenses is as a consumer issue in Australia today. Shared decisions, inclusion of family and friends in decisions, and these are just a few random quotes that we've included of the sort of feedback we get from consumers that brings us to those conclusions. Respect is about dignity, about timeliness. You know, I always ask health students, what's the one thing you bring to your doctor's appointment? And they say, oh, x-rays, my prescription. I say, no, a good book, because you're going to be sitting there waiting for a long time. Cultural sensitivity, real-time information, confidentiality, a sense of being welcomed and privacy. Integrated care, navigation assistance is probably the number one or number two thing that consumers ask for in terms of making their way through the health system. So it's one thing to have integrated care, it's another thing to navigate it. But they talk about, coordinated care, continuous, transitional, comprehensive, minimally disruptive care. These are the management issues that we think we need to pay more attention to. Validation, why have we got that? Because the number one thing consumers tell us is that time and time again they are considered to be unreliable witnesses to their own experience. I know that sounds odd, but whatever project of research piece we've conducted, that comes back to us over and over again. Empathy, it's about having a holistic approach, relating to the person and not just their condition. Relief of anxiety, compassion, comfort. So it's both a management tool and a quality of delivery tool. And then remedy. Why do we have remedy? Because the value of a system is how well it works on a bad day, not on a good day. And things, as we know, go wrong. And things consumers complain constantly about is lack of adverse event reporting, poor complaints handling processes, poor direction on remedial treatment pathways when something goes wrong. So patient-centeredness or patient-driven care is not just about what happens on a good day, but what happens on a bad day as well. And we would argue that patient-centered care without consumers having a role in management is just patient kindness care. So I guess our takeout from all of that is we've come a long way, but we think there's a long way to go. And as I stated earlier, the value of having conversations with consumers and having them right from the beginning is they don't know all the answers, but they'll make sure that you get the questions right. Thanks for your time.
Thank you, Danny.